Good morning, ladies and gentlemen. Thank you for joining us this morning. The topic for this symposium, Symposium 6, is personal health issues for both genders. We have two speakers with us this morning. One is Dr. Shankar Kupusamy from the University of Malaya. He's head of urology there. And the other speaker who will join us online is Dr. Kong, who is a consultant gynecologist and urogynecologist at Subang Jaya and Park City Medical Centers in Kuala Lumpur. She will join us online, but first I would like to ask Dr. Shankar Kupusamy to start with his talk, please.
Okay, thank you very much, Mr. Chairman, and also the organizing committee for the invitation to give my talk on urinary tract dysfunction in older men. As introduced, I'm Shankar Kupusamy. I'm one of the consultant surgeons under the Division of Urology in University Malaya Medical Center in Kuala Lumpur. Okay. Right. To make this talk a little bit interesting, because I understand that there are multiple levels of expertise among the audience, so I would take you through a journey of one of my patients, Mr. CSK, a 75-year-old Chinese man. He's a known diabetic and hypertensive. He has been on saw palmetto for the last 5 years, and currently he came to see us with a complaint of getting up 3 times in the night to pass urine. His urinary stream is weak, and he was feeling like as if he is not completely emptying. Okay, and he's also got frequency and urgency. Frequency means he goes to the toilet very often. Urgency means he cannot hold urine, yeah, so he needs to rush to the toilet. And this has been going on for the last 3 years, and is getting bad lately. Okay. So what does the patient have? What does Mr. CSK have? He actually has lower urinary tract symptoms, which is known as LUTS. In short, it's known as LUTS. So I will be using LUTS a lot in this talk. So LUTS has got many causes, most of the causes in the young, neurological causes and all that, but we will concentrate on these three conditions, which is more common in the older patients, which is nocturia and also overactive bladder, as well as prostatic obstruction, causing bladder outlet obstruction. Okay, and this overlaps, actually the symptoms and all overlaps. Now, talking about LUTS, it's a major burden in aging population, and it's very troublesome in almost 90% of patients aged 50 to 80. So all of us in the audience here who are above 50, we should slowly start having lower urinary tract symptoms, and we urologists will be quite popular among you, actually. Yeah, all right. So just joking, and out of all those conditions that can cause LUTS, benign prostate hyperplasia among the elderly more than 60 years old is very rampant in about 60% of patients. So the talk today will mainly will be concentrated on BPH. Yeah? And LUTS has got many symptoms. Like say, it's a group of symptoms. So at least majority of them will at least have one. Okay. So among patients with LUTS, the common causes is bladder outlet obstruction, also known as BOO, benign prostatic enlargement, and because of this, you get overactive bladder, or sometimes when the patient is chronically obstructed, the bladder becomes underactive. That means the bladder has failed. They cannot actually empty, and they may only leak urine. Okay, and because of issues with BPH, they can also have nocturia, which cause them to get up in the night. Now, what happens in BPE actually? Yeah? So before the prostate enlarges, no problem. Everybody passes urine, and once the prostate enlarges, it actually blocks the bladder outlet. Okay, obstructs the flow. Therefore, the patient will have voiding symptoms. Difficulty to. I will come to the voiding symptoms shortly, And next, after chronically getting obstructed, the bladder wall actually thickens, the tone of the bladder actually increases, and patient become overactive. So this is called storage symptom. They cannot store urine. Okay. So what does Mr. CSK have on further history? He has voiding symptoms like poor stream, intermittent flow, that means start-stop, yeah, start-stop. And then he has hesitancy. He is not able to initiate micturition fast. He goes to the toilet, everybody come and pee and go off already, he's still waiting, cannot pee. So that is hesitancy. Then, but he does not have terminal dribbling, which is another voiding symptom, and incomplete voiding. Okay. So what about storage? Storage has got urgency, frequency, and but he does not leak urine. He told us that he does not leak urine, but he has nocturia. That means about 3 times a night he has to get up to go and pass urine. Okay. So we always proceed to take further history. It's very important. History is very important because there are lots of issues in the history that can be sorted and improve the quality of life of the patient. So always take a good medical history, whether this patient is known diabetic and hypertensive. However, he's very well controlled with medication. And he takes saw palmetto, okay, which is one of those famous drugs. I'm sure you all heard about it. So it's one of those famous alternative medication for BPH. And he used to be a smoker, takes 2 mugs of coffee per day, drink lots of fluid day and night, and he does not have any neurological, psychological, or any sleep disturbances. Sometimes these sleep disturbances can give nocturnal polyuria. Okay? And he does not have constipation that can cause obstruction, and he did not also have any previous instrumentation that can cause stricture in the urinary system and cause outlet obstruction. Okay? So what I would normally do is I would administer this questionnaire. This is the International Prostate Symptom Questionnaire. Although it says prostate, it actually covers a lot of those voiding and storage symptoms. Okay? And it is a very common questionnaire. It's available in all languages in our country, and it incorporates all the symptoms. And it's very sensitive to pick up patients who are actually having LUTs. Okay? So as far as Mr. CSK is concerned, when we scored him for the IPSS score, he scored 20 out of 35, okay, which is in the severe group. And his quality of life was 4. That means he was mostly dissatisfied. The saw palmetto is not working anymore. Okay, so he comes to see the urologist. All right. So as usual, we would do a examination for Mr. CSK. I will palpate the bladder just in case he's got chronically obstructed failed bladder. And he did not have, and check, of course, always check whether the patient has got phimosis, very pinhole meatus, whether got any urethral discharge. Check for a gross neurological examination. We are urologists, we are not experts in neurology, but still gross neurological examination we can do. Okay? And then, of course, I will do a per-rectal examination. In his case, noted that his prostate was about 60 grams. We can estimate the size, yeah, roughly can estimate the size. Smooth and benign feeling. There's no suspicion of prostate cancer. Next, what I would do is I would analyze, I would assess the patient with some investigation. Because he had frequency and urgency, I would send a urine, just a full examination and microscopy, just to check whether he's got urinary tract infection or not. And because he's got medical problems, check whether he's got chronic kidney disease and also any hydronephrosis due to the back pressure on the kidney can cause renal impairment. And I would do a PSA because he's 75 years old, high risk for prostate cancer, and if I diagnose prostate cancer, the management will change. So it is important. And PSA is also a very good indicator for the size of the prostate. So in Mr. CSK's case, urine FEME had no UTI picture, creatinine was just mildly maybe CKD grade 1, PSA was 3.6, indicating a very large prostate. No? Okay. Then in a urology setup, we need to do a uroflowmetry. This is very important, okay? Because in his case, I am going to start him on some treatment, definitely, because I know his quality of life is poor. I am going to start him on some treatment. So I'm going to do a uroflow just to document what is his flow before I start the treatment. Okay, so it is something like a urodynamic study, and important to tell the patient, you must feel your bladder full, like as if you are going to have spontaneous micturition. It cannot be a forced micturition for uroflow. We don't want little bit and all that. So, and the Qmax is calculated, that means the maximum flow rate of the urinary stream is calculated by ml per second. So, and this is example of how the flow looks when the patient pees into the container that I showed you in the previous picture. Okay, so A here is the normal flow, you can see A is the normal flow, and B is called staccato flow, that means the bladder muscles are a bit hyperactive, can indicate overactivity. And you got interrupted flow, intermittent flow, where the patient actually uses abdominal muscle to strain, he's overcoming obstruction. So that is intermittent flow C. And D is the long flow, prolonged flow, like in the cinema, young men go, old men go. Young men all left already, old men still peeing, very common, isn't it? So that is what Mr. CSK had. Okay, he voided about 200 ml, good study, Qmax about 10 ml per second, which shows obstructed, and he had prolonged flow. Okay, now because he had significant storage symptoms like frequency, urgency, and nocturia, I would always do a frequency volume chart. Okay, this actually gives me how many times he void, how many times he drinks, how much he drinks, how much he voids, and whether he's got leaking of urine, what is the daytime frequency, nighttime frequency, and all this will be charted in this form here actually. Yeah? And also we can see whether the patient is having nocturnal polyuria. Now in the case of Mr. CSK, you can see that I have calculated down there the total volume. Nocturnal polyuria by definition is more than 33% of the 24-hour urine volume. In his case, he did not do that, he less than 33% actually. And he is drinking, you can see according to the time there, he is actually drinking massive. Every hour almost he's drinking quite good volume of urine. Okay, volume of water or some fluid. My apologies, sorry. Okay, too much into urine actually. Yeah, okay, yeah. And he did not have any incontinence. Yeah, and of course, bladder frequency volume chart must be repeated over 3 days. Yeah, so 1 day will not represent the actual situation. Okay, now ultrasonography is of course optional. We would actually do it if I'm going to consider surgical management. I can assess the size of the prostate, and most importantly in this picture, you will notice that there is something inside the bladder giving a nice heart sign there. That is actually the intravesical prostatic protrusion. Okay, it's actually attached to the bladder neck, but this picture was very nice, so I just wanted to show, to make a point here actually. So we always do it in presence of renal impairment, also if the patient can be assessed for post-void residual urine. That means after he passed urine, how much urine is left behind in the bladder can be assessed. These are all very important information for a urologist before starting treatment. So let me go to the summary of Mr. CSK now. What does he have? He has severe symptoms because his IPSS score was 20. Quality of life not good, very dissatisfied. He's got a large prostate, about 60 grams, has got OAB symptoms, has got nocturia but not nocturnal polyuria. Yeah? So he does not have nocturnal polyuria. His lifestyle, he's drinking a lot, especially at night also he drinks a lot. He's got coffee drinking, and his uroflow, when we did it, is obstructed. So these are is in summary what he has. So can I do conservative management and do watchful waiting? Many a times we do watchful waiting, but I'm not happy to do that because he's got bothersome symptoms and his score is severe actually. It's affecting his quality of life. So the first thing I would do is I will ask him to modify his lifestyle. I will sit with him, make sure that he actually drinks, reduce the fluid intake, especially in the night, and also phase out the drinking. He's drinking every hour. We don't drink every hour, isn't it? We need to drink in the morning, and then we drink somewhere late morning, and then lunchtime. We drink good volume one shot, and we don't keep drinking because people normally hear, no, must drink urine, must drink water a lot. I keep saying urine, I don't know why actually. You drink water is good, you mustn't be dehydrated. It's not the way to drink actually. You should drink, all our children will have one Tupperware in front of their table. When they have a thought block, the first thing they will do is they will drink water, isn't it? So this is not the way it should be done. You should phase out your drinking, drink good volume, okay? And then reduce coffee or alcohol. This patient actually take 2 marks, I think it's fine. Evidence have shown that 4 marks a day is not so good actually. But still, better to reduce when we are getting older. And if his post-void residual urine is very high, then we can also advise the patient to go double void, double void, so that he can clear the urine one shot. Okay? And also he can train the bladder to stretch by holding urine. Also our Dr. Google would have said, mustn't hold urine, mustn't hold urine. But if the patient has got no renal impairment, no back pressure effect on the kidney, actually you can hold urine to actually stretch it a bit, So practice, if you lose to the brain lose to the bladder, that's it. You have to move all your office to the bathroom actually in your older age, So shouldn't lose to the bladder, not the brain, shouldn't lose to the bladder. Okay, so what I started this patient, on alpha-1A blocker tamsulosin and dutastride, which is avodat. Why? Because bothersome symptoms, severe symptoms, and prostate size quite big. PSA also 3.6. Okay? Due to the size of the prostate, I have to start double treatment because the risk of urinary retention and him going to surgery is very high, based on this presentation. So a bit about the drugs, alpha blocker and 5-alpha reductase inhibitor. These are the example. Doxazosin, Cadura, Zatral, you would have heard about it. Tamsulosin is Hanal. And then finasteride is the famous Prosca. And dutastride is avodat. It's a bit more newer. And they work by relaxing the prostatic urethra tone, allowing relaxation of the prostatic urethra to pass urine. Whereas 5-alpha reductase inhibitor works by reducing the size of the prostate. Okay? And alpha blocker works faster than 5-ARI, and they all cause improvement in the IPSS score and also the Qmax of the flow rate. Yeah? So one is slower than the other. Okay? And they all have side effects. Yeah? Orthostatic hypotension is the most important side effect in alpha blocker, whereas impotence and decreased libido is one of the very important side effects in 5-ARI. Okay? Now, Mr. CSK was seen again after 6 weeks. After doing all this, come back with IPSS score 16, improve a little bit, quality of life still 4, mainly because he had all this overactivity, bladder not very well improved actually, didn't improve so much, but otherwise nocturia improved by little bit, 1 to 2 times. Earlier he was 3 to 4 times, now 1 to 2 times, but still not happy. He give you a score of 4. Okay? Now what to do next? So you can consider keeping him on this medication longer. Let's cut the story short. And what I would do in this kind of case, if the patient is still not happy, I would add on either an antimuscarinic like solifenacin, or I would add on the newer beta-3 agonist, namely mirabegron. This actually relaxes the bladder and allows the bladder to store more urine. Okay? So I started the patient on mirabegron, and I explain, of course, when the bladder relaxes, it can go into urinary retention. That's very important. Yeah? Explain to the patient the risks, and then you start the patient and review the patient again in 3 months. Okay? Mirabegron has got better safety profile compared to solifenacin. That's the reason why nowadays we are slowly moving towards mirabegron. If you have not heard of mirabegron, maybe you might have heard the word betmiga. Okay? That's the new beta-3 agonist drugs. Now this patient is on saw palmetto. Yeah? I just want to highlight a bit about saw palmetto. Maybe it will help you in advising our family members or our patients. The clinical benefits of saw palmetto is uncertain. We don't know actually. Yeah? And this is one of the very widely used drugs. How it works something like finasteride, where it has got it decreases the testosterone effect on the prostate. And this brand, all don't work the same one. They all don't work the same. And safety also, we are not sure. And how many minutes more? Okay. All right. So patient may go into surgery in the future if they do not improve. And some of the reasons why we would proceed to surgery is, of course, failed medical therapy, patient not keen to continue medication anymore, too many side effects, and getting recurrent UTI, bladder stone formation, renal impairment, already got renal impairment and hydronephrosis and recurrent gross hematuria. All this will make me decide, okay, we need to go for surgery. Mr. CSK has not reached this level yet. He's still quite happy with the 3 drugs. And surgical options are, of course, TURP, the gold standard. Still a lot of us do TURP, and some newer technology has come in with laser and also ablative therapy. So this is how a TURP is done, just for information. The prostate is enlarged. We resect the prostate using electrical current, either bipolar or monopolar. We create a cavity like that from the bladder neck. The urine can just flow freely, and this is probably my last slide. And complications of TURP is retrograde ejaculation, incontinence, and in the long term, patient may get stricture because of scarring. Okay? With that, I thank you for your attention, and I'm happy to take the question if Mr. Chairman would like to address the questions now or later.
Maybe we have a discussion at the end of
okay.
After. Thank
okay.
you. Thank you very much.
Thank you very much.
Yeah, I just need to. The next speaker is Dr. Kong Su Yen. I don't know whether she's on or not. Can we just check? It's a pre-recorded session, is it? Yes. Okay. Whenever you're ready. I think she'll join us for the Q&A after her talk. I hope.
Good morning, ladies and gentlemen. Thank you very much for your kind invitation to join you at your conference. My name is Kong Su Yen, and I'm a consultant gynecologist and urogynecologist. The title I've been given today is The Waterworks in the Older Woman, the wet and the dry of it. So what do we actually mean by wet and dry? Wet is really quite obvious. It means that the woman has got urinary leakage or incontinence. But of course, some of these women may actually be dry. So they have got no complaints of urinary leakage, but they do have significant urinary symptoms. And the two main categories these women may fall into would be either having conditions such as an overactive bladder or an underactive hypotonic bladder. So let's have a look at the Malaysian statistics. Now, I could only gather information regarding urinary incontinence and not so much about the incidence and prevalence of urinary symptoms per se. But let's have a look. From the Malaysian census in the year 2020, it's been estimated that the Malaysian population stands at just under 33 million people. And out of these people of age more than 65 and above, 2.3 million of them fall into this age group, and that would account for 7%. Now, from earlier studies done in the Malaysian setting, the estimated urinary incontinence was deemed to be around 10%. But more recently, in fact, last year at University of Malaya, we conducted a study called the MELO study, the Malaysian Elders Longitudinal Research Study, looking at the well women above the age of 55 years. We found that the prevalence of urinary incontinence was actually much higher, standing just under 31%, with Malays showing higher numbers at 38% compared to the Indians and the Chinese. So let's move on. So we can see that this is indeed a big problem, and this will only become a bigger problem as our Malaysian population increases in number. Now, from experience, we know that only a minority of these women actually seek help. And we're not quite sure whether this is due to their fear of seeing a doctor, or is it that they are unaware that, that this is indeed a problem. But to be honest, for most of these patients, this condition actually is very treatable and curable. And it is never just about old age, and it's never normal after childbirth. A lot of women think so. And we all know that having urinary incontinence or significant urinary symptoms can greatly impact on the quality of the life, and of course has been associated with serious health implications, both physically and mentally. So what do I actually mean when I talk about urinary incontinence? it means that the woman has got full bladder control and is dry. Now, for this to happen, you need to have a complex interaction and networks within the body to function well. And this, of course, includes the bladder, the urethra, the pelvic floor muscles, the endopelvic fascia, and of course, an intact nervous system. Now, because of time constraints today, I'm going to be primarily concentrating on the two main or most common type of urinary incontinence, namely the stress incontinence and the urge incontinence. So I'll cover each in turn. So when we're talking about the stress incontinence, it generally happens when you have a sudden increase in your intra-abdominal pressure. So typically women complain of urinary leakage associated with activities like exercise or when they coughed or sneezed. Now, predominantly these the main risk factors would have been childbirth, especially if they've had instrumental or traumatic vaginal deliveries. If a patient was postmenopausal, and of course, if they had particular stressors which would increase the intra-abdominal pressure, such as having a chronic cough, if the patient was obese, or if she had a large pelvic mass. And certainly there's a minority of these women who would also have collagen disorder, which will further predispose them to developing stress incontinence. And what about overactive bladder? So what actually happens in these patients is that the detrusor muscle actually starts contracting before the bladder is full. So these women typically complain of urinary frequency, urgency, nocturia, and of course, a percentage of these women would actually have urge incontinence as well. Now, interestingly, most of these cases of overactive bladder are actually due to an idiopathic cause, so we don't know. But we do know that certain factors do increase the risk, such as increasing age, if the patient smoked, if she had had previous pelvic surgery or radiotherapy, if she had had any form of bladder outlet obstruction, such as a significant cystocele, for example, or if she had a neurological condition, which was causing the detrusor to misbehave, as I call it. So, for example, they had poorly controlled diabetes or have had previous stroke. So what do I actually do with these patients when they come and see me in clinic? Well, of course, we always start with patient assessment, and that would encompass taking a thorough history, examining the patient, performing investigations, and of course, then thinking about tailoring the management to the most likely diagnosis. So really, from the history itself, we have a general idea as to what the likely diagnosis is. So as I've said earlier, if they complain primarily of urinary leakage associated with coughing, laughing, sneezing, exercise, this tends to point towards stress incontinence. And if she complained predominantly of having urinary frequency, nocturia, urgency, or urge incontinence, this will point more towards overactive bladder. And of course, bearing in mind that the woman could present with mixed incontinence, so having both stress and overactive bladder. Then, of course, there are also a group of women who may complain of dysuria with or without hematuria. And of course, this could indicate that she might have a urinary tract infection. And of course, also thinking about whether she may have any other pathology affecting her urinary tract, such as a calculus or a tumor. And if a woman complains predominantly of incomplete bladder emptying, the fact that she has to strain or lean forward or double void, and also if she had noticed the urinary stream being particularly weaker, then we have to bear in mind that she may have avoiding problems. So, think about things like whether she's got significant uterovaginal prolapse, for example. Or, as I mentioned much earlier, whether she may have an element of an underactive or a hypotonic bladder. Okay, so let's have a look. What else from a history? It's important to take a detailed history regarding her daily fluid intake, whether this includes any caffeine. Also to take a history as to whether she has significant bowel or prolapse symptoms. And of course, a medication history will be very important, especially if there was an element of polypharmacy. It might be also that they have an element of poor mobility and dexterity. We also have to think as to whether they may have any elements of impaired mental states such as dementia, and also to ask in detail as to how her urinary symptoms are affecting the quality of her life, and also, of course, bearing in mind the quality of life and the to her carers as well. So, what about clinical examination? So I would certainly take note of her body mass index and a general look at her functional status. And as we are talking about looking out for any particular stressors to the pelvic floor, we need to exclude any abdominal or pelvic masses. We should be examining the vulva and the vagina for any particular skin conditions such as ulceration, infections, but also, of course, as I mentioned earlier, for significant uterovaginal prolapse. And it's also very useful to actually see and ask the woman, cough for me, cough and see whether you can elicit any urinary leakage from the urethra. And if you do see this, this will confirm the fact that she's got stress incontinence. And investigation-wise, I would certainly start with urine analysis just to screen her for any evidence of urinary tract infection. And if there's any a strong indication towards this, then I would send the urine off for a full microscopy culture and sensitivity. And of course, bearing in mind that for elderly patients, it is sometimes quite difficult for them to catch a midstream sample, especially if they are not very mobile, if they've got a significant prolapse. And in these cases, I think doing a clean intermittent self-catheterization to get a urine sample will be useful. And this will avoid, obviously, contaminated samples. Doing an ultrasound scan in clinic to look particularly as to whether they've got any significant post-void residual urine. And if they do so, this may point more towards avoiding dysfunction problem. And of course, this will also let us know whether she's got any significant pelvic mass. So, from this scan that you can see, this patient had a very large pelvic mass as a result of an ovarian cancer. Now, last but not least, I would like to point out the importance of doing a bladder diary and asking the patient with perhaps the help of her carer to fill in a bladder diary. And this would certainly give us a lot of information regarding her bladder and her voiding patterns. So let's move on to the management. And as a general management, I think it's a good idea to advise the patient to have an average fluid intake between 1.5 and 2 liters a day. If she was obese or overweight, for her to encourage her to lose some weight and to stop smoking if she was a smoker. And of course, if she had any concurrent urinary tract infection or constipation, it's important to treat these conditions and to optimize any medical conditions should the need be. Okay, now specifically looking at stress incontinence, I wanted to remind ourselves that if the patient was physically able it is very important to refer her to the physiotherapist to be taught pelvic floor exercises, because this has been shown to help in cases of stress incontinence. But you need to warn the patient that she needs to be compliant and be able to perform these exercises long term. And to be able to see any benefits, you need to be able to do that for at least 3 months. The cure rate could be up to 70%, so it could be really quite significant. And of course, the physiotherapists may decide to use biofeedback with weighted vaginal cones or electrotherapy. So this is very much after the physiotherapist has assessed the patient and to see the need. And of course, if all conservative measures fail and the patient is confirmed to have stress incontinence, normally I would have performed a urodynamic study preoperatively. We can consider surgeries like mid-urethral slings, copal suspensions, or the usage of bulking agents. Okay, I'll quickly move on to management of overactive bladder. So it's very important to spend some time educating the patient and the carer regarding the bladder irritants. So majority of us know to avoid caffeinated drinks such as coffee, tea, Chinese tea. But many of us are not aware that fruits like citrus fruits, tomatoes, spicy food, for example, carbonated water, these are all bladder irritants. So, and of course, it's very important to educate the patient. And really from the bladder diary, you'll be able to have an idea regarding her fluid intake and the pattern of her fluid intake. So for example, if she complained predominantly of being troubled by nocturia, then it's important to actually advise her to maybe reduce the fluid intake 2 to 3 hours before bedtime. Pelvic floor exercises certainly would help too, and bladder drill exercises, which can be taught to her by the physiotherapist. We can also think about using drugs like topical estrogen and medications such as anticholinergics and beta agonists if the symptoms of overactive bladder were not responding to your conservative measures. And of course, incontinence devices such as, the diapers, the Inco pads, for example, are very useful tools to help us manage these patients. But of course, to bear in mind too that all these can incur a high cost to the patient and the family. And just really an aside, if the patient had long-term urinary incontinence, they could also be affecting the skin, and we should certainly bear in mind that they can develop pressure sores, eczema, and for us to actually consider using or use barrier creams such as pseudo-cream as an adjunct. Also, if the patient had a significant pelvic organ prolapse, to refer her on to a gynecologist or urogynecologist, because this certainly would be impeding her urinary function. And certainly not all of these women would require surgery. We could certainly manage them very successfully in majority of these cases with an appropriate vaginal pessary. So really, coming to my last slide, take-home messages is that urinary incontinence is a common problem, and probably a commoner problem if we were to take women with any kind of urinary symptoms. It can greatly affect the quality of a patient's life, and certainly cause a high cost to herself and the family. It's very important to do a thorough assessment to come to the right diagnosis so that we can actually institute effective management for her. And this can take the form of conservative medical or surgical intervention. So with that, that's my last slide. Thank you very much for your attention.
Thank you. Thank you, Dr. Kong. We have about 5 minutes, So I can see from the audience, most of you over 50 years of age. So if you have a, Dr. Shankar, can I get you up, please? If you have an uncontrollable urge to ask a question, please do so.
That's a good one.
I don't see anything online.
Yeah, just say hi to Kong. Hi, Kong.
Hello, Professor Prana, Prof. Shankar. I'm here. Can you hear me?
Yes, very clearly.
Great.
Work together.
Thank you for having me. Sorry I can't be there with you in person.
Dr. Kong, while you're there, can I just ask, it's a very strange thing. I had a dog who used to get very excited and pee whenever she saw me, and she was a young dog. That's not urge or stress, is it? Or it's just excitement?
Well, I'm not quite sure. I suppose whenever we get excited or get nervous or anxious, especially preparing for exams or an interview, we normally need to go to the toilet a lot more often. So maybe she was getting super excited at the sight of you. But it's interesting because a lot of patients who do have overactive bladder, all right, if and when they see the toilet, I suppose, or when they drive into the porch, they see the front entrance, they see the door, or as they're putting the key into the lock, they suddenly get this sudden urge. And in fact, there's even a term called latchkey urgency. So various triggers can actually, be it certain sights, certain sounds. There's some people who get triggered off by the sound of running water, or when they're washing their plates and doing the dishes, or when they're in the shower, or maybe just being in a cold environment. So all of us have got different triggers. So I'm not quite sure.
Okay, thank you. Are there any other questions? If so, we have to vacate the hall by, we've got another 3 minutes. Anything for Dr. Shankar? Surely there must be somebody here who's got a urge to ask a question. There.
Yeah.
Yes.
Hi, Dr. Shankar. Betmega comes in 2 strengths, right? I believe 25 and 50.
Yeah.
So it's once a day dosage.
It's once a day.
And how do you decide on the strength of the? Can it be used for both men and women?
Can be used both in men and women. Yes, you can. You can. Prof. Kong's slide had beta-3 agonist as one of her treatment option for overactive bladder. Yes, you can use in both male and female. Okay. And my standard dose is 50 milligram.
50, yeah.
Because 25 milligram, I'm not sure why it is there in the market, because the efficacy is almost the same, and the cost is also almost the same actually.
Right.
So you don't need to use 25 actually. You can just go ahead and use 50.
50, yeah.
Yeah. Okay. Safety profile and all are all the same actually.
Okay. Thank you.
Dr. Shankar, can I ask you, our urology department, at least the one in Perak Hospital, 2 main classes of drugs for BPH, either to shrink the prostate or to relax the sphincter. Yeah. But they have now introduced for the past few years Cialis low dose. Yeah. How does that work?
Yeah, Cialis low dose has come widely now. People are using it. This is used for patients who have some form of erectile dysfunction as well. If they have some sexual dysfunction, yes, you can add on Cialis 5 milligrams daily on top of the alpha blocker or 5-alpha reductase inhibitor that you.
But it's not for the BPH per se.
It is. It has got effect on the BPH. In fact, Cialis, they are now trying to come up with evidence to show that Cialis can be used even as monotherapy. Alone for BPH actually. Yeah.
Dr. Kong will have no such worries.
Yeah.
No, not a drug I'm familiar with, but I'll just add on to the Betmega. I would normally be giving the 50 milligrams to my patients unless they've got severe renal impairment or liver impairment. In those cases, you might want to start with the 25 milligrams. Also, I think to be a little bit more careful with women who've got residual urine. So for my women, they may have significant residual as a result of a large vaginal prolapse, and as a result, they may not empty so well. And in these women, it might be giving them the high dose of Betmiga may, push them into retention. It's very rare that happens,
Yeah.
but those are the groups of women that I'll be a little bit more careful in.
Yeah, you cannot give if they have residual urine more than 150 ml, especially in males. You should not start somebody on Betmiga.
Okay, thank you very much. I think that's all that we have time for this morning. I don't see any other questions. Dr. Kong, thank you very much. Dr.
Thanks.
Sugar,
Thank you very much.
Thank you for having me. Yeah, thank
Can
you.
we just thank the speakers in our usual manner? Thank you very much.
Thank you.